Good evening, one and all. And also, I'd like to thank the entire Diabetes India team for giving me a great opportunity. Friends, managing diabetes among the primary care is very important, the clinical practice, because we see in the Indian population, almost 70% of the Indian population are from villages. So, this diabetes management among the primary care is the centricity and center point of the diabetes management, also diabetes preventing complications. So, integrated care is very, very important. Even though glucose control is the main centricity, but this should be followed along with the other important features because we are in the precision diabetes area. We are implicating precision medicine, the right time, the right therapy, at the right patient. So all the things should be implicated according to children's age and comorbidities, mental stress, emotional support, adults, and also we have to take up older patients also because sarcopenia and the strengthening of muscle nutrition support. So these are the background we want to consider among the primary care setup according with the lifestyle modification, including physical activity as well as the dietary pattern. So this is the decision loop algorithm pattern that we want to implicate. Our treatment goals is to prevent the complication and optimize the quality of life. That is very important. And this can be applied by the accessibility, the key person characteristics. And also we could consider about the specific factors that impact the choice of treatment and utilize the shared decision, implement the management plan according to the patient status and the patient comorbidities, which patient need which therapy, cardiovascular drugs and kidney drugs and so on and so forth. We want to implicate in the primary care and we want to emphasize the primary care consultants to not only control the glycemic burden, but we want to prevent the complication. Traditionally, we have this classification. We know type 1 diabetes, we know type 2 diabetes, and GDM, we have LADA, MODI, secondary diabetes, pancreatic diabetes, so on and so forth. So if you see the screening, what is the criteria for the screening of diabetes, including the pre-diabetes? Those the subject who are high risk, those who are the HbA1c more than 5.4 or 5.8, those who belong to the high risk factor belong to families, Indian phenotypes, obese patients. So these are the areas, and these patients should be considered for the pre-diabetes screening as well as for the diabetes screening, and once for all. So these are the diagnostic criteria. So any patient having HbA1c which is 5.7 to 6.4 pre-diabetes and more than 6.5 is diabetes and fasting sugar between 100 to 125, we all know about that. And see the postprandial is 140 by 199 is pre-diabetes and more than 200 is diabetes. So that's a very, very simple thing. We want to emphasize the primary care consultant in the rural setup, in the village setup also, so that we educate them properly in all aspects to prevent the complication. More than hypoglycemia also should be emphasized because one single hypoglycemia will result in a lot of cardiovascular complication, including the cardiac autonomic neuropathy, this one, and cardiac arrhythmia, going for sudden death and loss. Because this hypoglycemia will impair the glycemic variability, increase the glycemic legacy, and land up in cardiovascular morbidity and mortality. Because hypoglycemia is a marker for the oxidative stress and implicating for the cardiovascular complications. How to prevent or delay the type 2 diabetes? This is a pre-diabetes algorithm. Annual monitoring is very, very important. Lifestyle program, eating pattern. Metformin for prevention of diabetes in case high risk patient, obese patient, those are high insulin resistance. And also taking care of the cardiovascular risk factors and also personalized central goals is very, very important. Accessing glycemic because we are traditionally we are been using HbA1c and SMBG is a gold standard, but we are in the era of digital target. We are using therapeutic technology and digital tools in our clinical practice. We are implicating this one AI in our clinical practice, integrating with the AI and SMBG so that we can do more and more, and we are implicating the CGM in our clinical practice. So these are the things, simple things can be we can educate the primary care consultants so that they also may be knowing what is the concept behind the CGM, because CGM, you lose the importance of higher glycemic variability, and also they can easily identify whether patient going for hypoglycemia, and is one of the marker for the microscope complication. This is the glucose assessment. And time in range is very, very important. Time below range and time above range. We all know about that. I don't want to detail this. So the thing should be implicated, and also we want to educate the primary care consultants regarding the importance of CGM in the clinical practice, because all the type 1 diabetic patients should receive the CGM, and also the patient with a bizarre abnormal glucose oscillation type 2 diabetic patients also should be receive CGM, and in some cases GDM also should receive the CGM. Manual diabetes, non-pharmacological management and pharmacological management. So in this non-pharmacological management, in Professor Sam G.P. Mose will be telling all the conferences. See, all the diabetic patients should become a diabetologist. That is called as DSMES. Diabetes self-management education support is very important, and along with the medical nutrition therapy, because medical nutrition is integrated part of the diabetes management. Without these, the diabetes management is not fulfilled. These are the cornerstones in the management of diabetes, including physical activity, smoking cessation, and psychosocial somatic. Because type 1 diabetes, most of the diabetic patients, most of the type 1 diabetic patient, elderly population type 2 diabetic patient will have some sort of a mental disturbances and psychosocial impact. Very important slide. This is latest ADA 2025 standard of care. We know that previously used to start metformin, then SU, then so on. So for now, if we before the metformin itself, if a patient having the established ACVD or iris for ACVD or established HF or iris for HF or established CKD, there are modern drugs. We have insulin beta, we have GLP. Now there are both GLP and GIP. We can utilize these molecules like EMPA, DAPA, we have liraglutide, we have semaglutide. So these molecules can be, because most of the rural area doctors, they doesn't know about this molecule. We have to empower them, educate them, emphasize them, that we will tell more and more about the Bharat Sabha will be telling more, highlighting what are the things should be done in future regarding the village setup to emphasize primary care physicians to implement this molecule. Once again, the goal targeting weight management, there are multiple agents. We are there tirzepatide. We are going to have the tricretins also. We can utilize accordingly to prevent the complication. Not only for the metabolic burden, but we have to take care of the cardiovascular overcome burden and also the kidney overcome burden. Occur the segment of CKD armamentarium and the CV armamentarium, metabolic armamentarium, we want to address, including the MASH as well as the OSA. So these are the available glucose lowering agents. We have modern molecules, dapagliflozin, empagliflozin. We have GLP, we have GLP, GIP, and we have triglycerides also. We have depot inhibitors, glitazones, SUs. I don't want to go in this August audience because these are the subjects should be given only by the primary care physician. We should explain the molecules, where the molecules should be implicated for the right patient, because the right patient to get received, all the elderly population patients, they should be benefited with SGLT inhibitors or depot inhibitors, because these are the molecule doesn't go for hypoglycemia. It controls the glycemic burden also, but we can prevent the complication also. We want, our aim is to prevent the complication, MACE benefit, CV death benefit, all cause mortality benefit, HSF benefit, and CKD benefit will be attributed by this modern molecule, including this one, SL limiters, and as well as the GLP and GIP. What are the new algorithms? New algorithms is very, very important, because we are in the era of genomics. We are implicating pharmacogenomics, metabolomics. So what are the new algorithms? These are new algorithms. Decision algorithm is very, very important. First, we have to diagnose the patient by means of HbA1c and so on and so forth. Assess the type 1 or type 2, lifestyle implication. If the HbA1c is more than 7, start metformin. If the HbA1c is still high, you have some other molecule, modern molecules have to protect the endocardium, vascular endothelium, and also for type 1 diabetes, basal bolus regimen. And very, very important, the day 1 itself, we want to access the complication by means of doing retinopathy. We are implicating artificial intelligence in our clinical practice itself among the type 1 diabetes, so type 2 diabetic population, to screen and to search for the retinopathy. The early screening of retinopathy is very, very important in our clinical practice among both type 2 diabetic patients as well as the type 1 diabetic population. First line therapy, 1 second metformin. Consider the early combination that will be early emphasized by UKPDs. Any patient HbA1c more than 8.5, consider the combination therapy, because early aggressive glycemic control will have the benefit of microscopic complication, and to some extent of the macroscopic complications also. Our area to mitigate the cardiovascular, cardiorenal complications. Weight management, once again, very important. We have utilized the modern company, insulin betas, GLP analogs, and we have used in weight neutral molecule. Hypoglycemia risk reduction is very, very important. Hypoglycemia may increase the burden of both glycemic variability and also the cardiovascular complication, including the ventricular arrhythmia and ventricular tachycardia. Holistic approach, even though the holistic approach is very, very traditionally, but we want to implicate the right treatment for the right patient to prevent the complication, including both macroscopic and microscopic complication. Once again, very, very important, because nowadays we are getting a lot of new onset diabetes among the younger population. So we want to analyze, if you get a new onset diabetes, first we want to see whether the patient belongs to type 1 diabetes or type 2 diabetes or MODY or some other thing we want to see. So accordingly, we want to plan, or we want to implicate the treatment, so the diagnose early, the assess, access, and act. This is very important that we want to keep in mind, and also we want to educate the other primary care consultant to implicate in their clinical practice to prevent the complication. Once again, yes, risk factors should be applied, and they will educate all the diabetic patients should be screened for the cardiovascular, because The previous speakers were telling about the earth diagnosis. Almost 60 to 70% Indian population have the subchlorotic atherosclerotic cardiovascular diseases. So identifying hypertension, targeting hypertension, lipid management, because most of the diabetic patients will have normal LDL, but they have lipoprotein little a as well as small dense lipoprotein, lipid particles. These are highly atherogenic. So they should be identified whether these have this problem, because we are in the era of modern era, or we want to see the some other lipid abnormalities, including LPA as well as the small density lipoprotein. Once again, CKD. At diagnosis, at the day one itself, the patient should be subjected for microalbuminuria estimation as well as UACR, because if we miss the microalbuminuria, then we're missing the vascular endothelium dysfunction. That is very, very important. For type 2 diabetes, day one. For type 1 diabetes, at 3 year, at third year, or 5th year, or 5th year, they are implemented. And we want to implement the right treatment, ACE inhibitor, ARB, and so on and so forth. Now we are there of
Sir,
modern
time is over.
medicines, complex algorithm we have vaccination, including we have. So practical, these are the practical education, shared decision making, accessible technology, shared screening for the complication. So my dear friends, before closing this is the important message I want to render for all colleagues here, and also for all diabetic patients across the globe. The primary care physicians should be necessitated and emphasized for these 5 years. This is sitting, stepping, sleep, sweating, and also strengthening. Thank you very much for the great opportunity.